you are there, and
Yes,
Dr.
yes.
Yeah. So let's start. So very good afternoon to everybody. So we are into another session of the ICOG program. The Journal Club and the Clinical Research Committee are happy to have you all here. So, so to start with, we would like to introduce the entire organizing committee. I hope my screen is visible. So, the FOGSI, ICOG, JOGI Research Methodology and Journal Club. So, today is the 10th. So, we are very happy to have the usual format. So, there is one on research methodology followed by presentation of the journal articles. Two of them are there. So, it is a clinical validation of calf circumference and DEXA scans as a measure of muscle mass to assess the sarcopenia in community settings in Indian postmenopausal women by Dr. Renju, and the role of social support in reducing the severity of menopausal symptoms among women living in rural Mysore, Karnataka, and analytical cross-sectional study, Dr. Vidya. So I am sure it's going to be very interesting. So we have experts with us, Dr. Sudha, Dr. Hefsiba, Dr. Sheila Mane, Dr. Ragni Agarwal, and Dr. Anju Soni. And we are also happy to have Dr. Sudha coordinating this event, and Dr. Charmila has not been able to join us. She would join us a little later. So that's me. So I am the convener of this program. Dr. Charmila is also there with me. We have the support of Dr. Jaideep. I think we all, he doesn't need any introductions. He is the president of FOGSI and a gentleman, thorough gentleman, and he's been having a lot of accolades to his credit. We have Dr. Parul Kotedwala. He's an endoscopy surgeon and consultant gynecologist and chairperson of the ICOG. And he's the vice president of ISOPARB. And as you can see, the screen is filled with his numerous accolades. So, Dr. Parul, before we go to the next one, would you like to address the gathering now?
Well, thank you for asking me to be part of this very valuable and important aspect of our fraternity and our specialty. Unfortunately, we have large mass of clinical practitioners and they somehow refrain from participating in such academic activities. Of late, I have seen that people have now developed interest, and even small private practitioners also think of collecting data and doing something about it. So the first presentation will be very important about data presentation. And then, of course, both the papers basically focused on menopause will be of great value to all our younger colleagues, especially about reading the paper and critically evaluating it. So I wish you a very good program as always. Thank you for asking.
Thank you. Thank you very much, Dr. Parul, for being there. So going on with the rest of the team. So we have we also have Dr. Madhuri Patel. Other than being a Secretary General of FOGSI, she is Editor-in-Chief of JOGI, and JOGI, which is partnering in this program. And in fact, she was to be the speaker. Unfortunately, she is caught up in another event, so she is not able to join us today. She would be speaking on her topic at the next session in October, on the 8th of October. Dr. Sheila Mane, she's the ICOG Vice Chairperson, and she's also the expert for today's session. And she's a member of the IMS Bangalore, past president of Bangalore Society of Obs and Gynae, and the numerous honors and awards that you can see on the screen. Warm welcome to you, Dr. Sarita. She is the president of MOGS 2021-22, and she is also the secretary of ICOG, and she's the chair of West Zone India Representative Committee of ICOG, and Joint Secretary FOGSI 2017, Quiz Committee Chairperson. So, Dr. Sarita, would you like to address the gathering?
Yes, thank you very much, Dr. Radhika, for that warm welcome. And I take this opportunity to congratulate Dr. Charmila and Dr. Radhika. They're doing a fantastic job of organizing this FOGSI ICOG JOGI joint program every month. This time it's wonderful that the focus is on menopause, and I can see that you have leading experts on menopause. Dr. Sudha Sharma, of course, who is the coordinator, Dr. Anju Soni, Dr. Hepzibah, and I'm sure that it's going to be a really excellent evening. So without further ado, I would like you to please go ahead with the program. I wish you all the best.
Thank you. So, moving on.
Also, sorry, I just also like to thank Aristo Pharma for supporting this program right through the year.
That's great. Yeah, that certainly means a lot for us. So we thank you very much, Dr. Sarita. So we go to the first session, and that is the research methodology. And so that's me. Like I said, Dr. Madhuri was not able to join us today, so I'm going to be speaking on the important aspects of data presentation. So what I'll need to do is stop sharing this and then go on to share the other slide. Hopefully my slide is visible.
Yes, yes.
Okay. So I am going to be speaking on the presentation of scientific data. So, I'm sure now with the advent of webinars and online presentation, I think literally everybody would have had the experience of presenting scientific data one way or the other, be it the journal club or one's own scientific, whatever the basic research that one has done. So it is important for us to do an appropriate way of, having a presentation so that we are lucid. There is always a time constraint for one's talk. So you should be able to present your data. It's like a mini skirt. It should be interesting, but covering the entire topic. So that is the way your talk needs to be, and therefore it is imperative that you have your data presentation which doesn't appear too dry. At the same time, it has to be interesting. So it should be presented in an attractive way, compact and simple to allow for the conclusions to be drawn only by simply eyeballing, just by viewing. And it is important to choose the type of graphic which is most suitable for the variable that you wish to present. So for instance, here you have the pie chart, then you see the pictorials, and then you also have the maps, the geographical maps. So these are a few, examples of presentation of data, and there are many, many more. This is just not even the tip of the iceberg. So for us to enable, to have the presentation of data, it is important for us to identify the types of data that we are dealing with. So the data could be quantitative or numerical, or it could be qualitative or categorical. So as the name denotes, quantitative or numerical is numerical data. So these could be continuous or discrete. So when we talk about continuous, it represents measurements. One goes into the other. So height could mean 5 feet, 5.1, 5.2, and same could be the case with weight. So these are continuous data. And the discrete data is the one that can be counted. It may not have a continuity. Example, the number of visits in a hospital, number of males in a group. So these are examples of a discrete data. And then you have qualitative or the categorical data, and this is basically a descriptive information. This could be nominal or ordinal. So nominal is color of the eye, marital status, dead or live. It's basically yes or no answer, meaning two possible possibilities are there, right? Male or female. Binary is a type of nominal data. There are many more variations that are there. And ordinal is basically the gradation. For example, grades of breast cancer. It could be grades of pain. It could be the amount of bleeding in a case of abnormal uterine bleeding. So these are categorical ordinal data. So once you identify the data, you need to decide how you would like to showcase your data in your scientific presentation. So I'm going to basically talk about the tabular and the diagrammatic presentation. As we all know, the presentations could be presentation of data could be in many, many more ways. I'm just going to today focus on the tables and the graphs, right? So starting with the graph could be, basically the classification of the table and the graph. The table could be formal, or it could be textual, or it could be a matrix. Okay. What each of these means, I'll just show in the next slide. The graph could be for quantitative data, a histogram, frequency polygon, frequency curve, and for the qualitative, bar chart, pie chart, and the map diagram. So how this works, that is what is going to be shown in the next few slides. So what is a table? It is a systematic and logical arrangement of classified data in rows and columns. I'm sure we all know that. It simplifies our complex data. It is the unnecessary details and repetitions of data are avoided in tabulation. It helps to compare the various types of data, and it reveals the pattern within the figures which cannot be otherwise seen in the narrative form. So it displays the data and the text to support the main topic of a presentation. It's a very powerful visual reinforcement when comparing precise individual values or when multiple values of a unit are to be, but it is important also to display the units of measurements while we are doing this, while we are comparing the individual values. So basically, like I said, there are three types of tables. These could be formal, textural, or matrix. So what does the formal mean? It is numerical data in columns and rows. I am sure we are all familiar with this, doesn't require any further description of this. Textural is when there are word tables which are displayed in words and phrases or sentences in a list form. This is commonly used for qualitative study, which doesn't have quantitative data. It is like interviews, when you are doing a social behavioral aspects of a study, or when you are holding interviews where you want to verbatim, transfer the data for the presentation. So this is textural table. Matrix is a tabular structure which uses numbers, short words, or symbols. Combination of the two, matrix is a kind of a complex table. So the contents of a table for presentation are different for the one that is used for a publication. When you're doing it for a publication, you could have consider having a complex kind of a table where the person has more time to go through the table. Whereas when you're presenting it, it has to be very simple so that the person who eyeballs it just gets an idea of what you're trying to convey. So they are because the listeners are more often interested in the final outcome, and they want to know in short what exactly is the outcome of your study more than anything else. So this slide is extremely important for all of us to know the rules of tabulation. It is important to have a table number. Title has to be concise and self-explanatory. Content should be very clearly defined. Subtitles should be properly mentioned in the columns and rows. Unit of measurement should be very clearly mentioned. And any short symbols need explanation in the footnote. There should be a logical arrangement of the data in the table. And most important, don't clutter it up. So usually more than 4 columns and more than 7 rows are not generally liked. Better to keep it short and sweet. About 7 rows and 4 columns is the maximum number of columns that a table could have. So these are some examples. So this gives the diseases. This is the number of cases. So this is a kind of a textural table. This is a matrix table where you have everything written. You have the words, you have various levels of the blood sugars which are indicated, the male and female, and the number of diabetics, and this gives the total. So this is actually giving the class interval as well as the frequency. So you can get a lot of information from this table. So just by eyeballing, one gets to understand what is happening in terms of diabetes among the male and female, and what is the maximum number, what is the fasting glucose level in each of these category of the participants. So this is a matrix table, and it's a table which is you just observe that the number of columns here are 1, 2, 3, 4, and the number of rows are just readable, and the number of rows is 7 after including the title as well as the footnote, even if it is getting included in the table. So keep it short and sweet. That is the idea. So this is a badly compiled table. So look at the color of the table. Too much, color. Too many colors are there. Number one, and then the combination of color is not pleasing to the eye. Very difficult to make out the fonts. Right. The units are not very clearly mentioned here. There is, in fact, it's not mentioned at all. Alignment of the numbers are better placed centrally than to have in the left or right aligned. So that is also important to see. And the table, these grid lines are very thick. They are actually overpowering the actual data. So not a good idea. So this is a badly compiled table. So then we go on to the graphs. So it provides information at a glance, like I said, and we also enumerated the various types of graphs that are there. So starting with the histogram, it is a series of blocks, and it is basically for quantitative continuous data where there are no gaps there. So like we had said, age, weight, height, blood pressure, blood sugar. So x-axis shows the class intervals and y is the frequency. So just by looking at this, the serum cholesterol, you look at the distribution and you know that maximum number of people have it between 201 to 210, right? So very easily understood. The frequency polygon in the same histogram, if you were to join the midpoints, then it forms a frequency distribution over the histogram. And this gives us again a representation of a frequency table. And this is, whatever plots has been done on the histogram, it gives a pictorial view of the same. Line diagram is a comparison between two variables which are plotted on the x and y axis. And x is a measure of time, place, or event. Y has a percentage of or measures of quantity. It shows the trend of an event. So the bottom line in this, the take-home message from this slide, use a line diagram for the trend of an event. So occurring over a period of time. Infant mortality, cancer deaths over a period of time. It could even be the birth rates, right? So then you have the bar chart. So we talked about continuous data. Then we also talked about the trend. Now we are talking about the categorical data. So this is by a bar chart. So the bar chart has got spaces here. Histogram doesn't have space here. So it is rectangular bars of equal breadth. Each represents one variable or an attribute. So here you have chronic respiratory disease, pneumonia, cerebrovascular. So here histogram would not be the appropriate graph to choose, right? Here it is bar chart. So the width and gap between the bars is equal throughout. Height is proportional to the magnitude or frequency of the variable, and bars may be vertical or horizontal. So pie chart is a discrete data for qualitative characteristics. Again, it is for categorical data. So here you have, for example, you want to indicate within a short span the frequency or prevalence or distribution of a certain attribute. For example, it could be blood group, Rh factor, age. So here of an entire 360-degree pie, you in one pictorial graph show what percentage is taken by which group. So this is the table that you can find here. This is the pie chart. So very easily understood by one single look at it. So the frequency of group are shown in the circle, which may be color or coded. Coded, and the degree of angle denotes the frequency. So these are the statistical maps, like I said. So here you have the geographical areas which are mapped out in different colors, and one could either have a legend here which shows the frequency distribution, or you could have the numbers written within these the color coded areas. So they could be different colors, or they could be the same colors with different intensity, and that would provide us the key for the distribution. So this could be geographic or administrative areas. And so this could be a statistical map, or it could even be a dot map. So this is a scatter diagram. It provides a quick visual display of the association between two variables, both of which are measured on the numerical, continuous or discrete scale, irrespective of categorical or continuous data. Here it gives an association or a relationship between the two variables. So here it is a positive linear relationship, it's a negative linear relationship, negative non-linear relationship, and there is no relationship. So this is very, I would say, a very good way of, simply presenting through a graph the association between two variables. So the practical tips are categorical data, both frequency and percentages can be used, can be displayed using a bar or a pie chart. And pie chart is only used to display one group of variables. Continuous data is by mean and standard deviation, which is symmetrically distributed. Median and interquartile range are for skewed data. Numerical precision should be consistent throughout. Summary statistics, meaning the mean and standard deviation, should not have more than one decimal place. So a table of or a graph, it depends on what you're wanting to do, whether you're wanting to publish or to present your data. So the graph is good for presentations. It shows all the data, but the problem is can only show few variables. Table is better for papers, meaning publication, can only show the summaries, and it is better for multiple variables. So these are examples of data which are not well presented. If there is no legend, there is no title, and the main data gets hidden in the chart. It is not, things are so small. 3D graphs are generally not considered very good, the three-dimensional one, because very difficult for the eye to make out the difference between the various data. So again here, better to have the countries presented in an alphabetical order, and then the most populous country can be seen, but the other countries with similar population are not immediately seen. This is the same data which is presented in a better way. So this is an example of a bad and a good data presentation. So I would like to conclude to say that information should be maximized for minimum amount of ink. Numerical precision should be consistent throughout. Number of observations should be included in both tables and graphs. Categorical data can be displayed using either or both bar chart or a pie chart. Histogram is preferred for quantitative data, and to show the correlation between two continuous variables, or in fact also the categorical variables, scatter diagrams are preferred. So thank you so much for a patient hearing. So are any of our experts here now? Dr. Sudha, would you like to give your comments?
Yes.
And I can see Dr. Sheila Mane and Dr. Hepzibah are also there.
Yes.
please. Yeah,
A very good evening, everyone. Thank you, Dr. Radhika.
Can you hear me?
It was a very informative, very crisp, to the point presentation, and I'm sure the audience must be benefited with this. I think there is no need to add on anything in it. You have covered it on a larger scale. Thank you very much.
Great, thank you very much. Dr. Sheila,
that was so-
I can see Dr. Okay, Dr. Hepzibah, please. Yeah.
Yeah. It was a wonderful presentation. You made it very clear and crisp. Thank you. And for the juniors will be definitely benefited.
I think you're taking a walk, Dr. Hepzibah. We are not able to hear you clearly.
No, it was a
nice.
wonderful presentation.
Okay.
These programs, and we are
Dr. Hepzibah, you can switch off your video. Your internet connection is not very good.
Very low. Yeah. Now we are able to hear.
Yeah,
Yes,
we can hear.
now we can hear.
Yeah, that was a wonderful thing. Even I learned few things, how to present. And I think juniors will be definitely benefited by your talk. Good presentation. Thank you.
Thank you very much. Dr. Sheila, please. Welcome to you, madam.
I agree what Dr. Hepzibah says. Actually, even we were not exposed, Now, to some extent, as we are in medical college, we do get exposed to research methodology and all this medical education. And we always look forward to your talk, because we feel you are an expert, and in a brief time you deliver the deliverables. So thank you very much for your excellent talk and a lot of learning. Thank you.
Thank you very much for the appreciations, madam. So we now can go on to the next session. So I hand over to Dr. Sudha to take forward the next session on the journal club, please.
Okay, thank you, Dr. Radhika, for that, and thank you, ICOG, for giving us this opportunity. And I think without wasting time, let us start the next session, that is the paper presentation in the journal club. And the first paper is clinical validation of calf circumference with DEXA scan as a measure of muscle mass to assess sarcopenia in community settings in Indian postmenopausal women. And for presentation, we have Dr. Renju with us. Dr. Renju.
Good evening, ma'am. I'm here, ma'am. Can I start the presentation, ma'am?
Sure.
Yes, ma'am. Good evening, faculties and dear experts. Thank you so much for choosing me to be a part of this wonderful journal club. My article has been taken from the April to June 2024 journal of Midlife Health is the book. Can I go to the next slide, please? The article is clinical validation of calf circumference with DEXA scans as a measure of muscle mass to assess the sarcopenia in community settings in Indian post-menopausal women. Next slide, please. Before moving on to the actual presentation, I would like to enlighten on a few terms. What is sarcopenia? Sarcopenia is nothing but the loss of muscle mass, strength, and the function. From the below picture, we can assess that as the age increases, the muscle mass decreases. But not only the mass decreases, its strength and function, everything decreases in the postmenopausal women especially. The second terminology is CC, that is calf circumference. Now, how do we measure it? It has to be measured in the standing posture with the feet 20 centimeters apart with an elastic tape. Average of 3 readings is taken into account. And the third terminology is ASMI, that is appendicular skeleton mass index. Now, what is it? It is the sum of the lean muscle mass from both the arms and the legs. It is calculated by the sum of the lean muscle mass divided by height squared. This is used mainly to assess the muscle depletion. Next slide, please. So here, of the total body mass is divided into fat mass and the fat-free mass. This fat-free mass comprises of the bone mass and the lean soft tissue mass. This lean soft tissue mass comprises the axial skeletal mass and the appendicular skeletal mass. Appendicular skeletal mass is the muscle mass from the arms and the legs. This can be measured with MRI, CT scan, and the dual energy X-ray absorptiometry. The next slide, please. This is the machine, and this is how they give the report as the total fat mass, bone mass, lean mass, etc. Next slide, please. The next slide, please. The aim and the objective of this study was to validate calf circumference as the reliable tool for measuring the muscle mass in the postmenopausal women. And the second aim was to identify the cutoff points for the calf circumference in our Indian women. The next slide, please. The study was conducted in Ram Lohia Hospital, Delhi. It was a cross-sectional study conducted from February 23 to September 23. 30 postmenopausal women were included from the OPD for this study. The muscle mass was measured using the calf circumference. Appendicular skeleton mass index was measured using the DEXA scans for the same patients. The collected data was analyzed and statistically evaluated to clinically evaluate the reliability of calf circumference for assessing sarcopenia in postmenopausal women. Next slide, please. The women who had surgical menopause, premature menopause, chronic debilitating illness, and the morbid obesity were excluded from this study because they themselves will have sarcopenia. The limitation of the study, however, is a very small sample size. Only 30 women were included. Ethical committee approval was got, and informed consent was obtained from the patient, and there is no conflict of interest. Next slide. The Asian women of the Asian Working Group for Sarcopenia says the cutoff point can be 33 centimeters for the calf circumference. ASMI, that is appendicular skeletal mass index, was calculated using the DEXA scans, and the cutoff point for the low muscle mass was 5.4 kilograms per meter squared. This was calculated at IBM SPSS, and the receiver operating curve was used to analyze the sensitivity and specificity variation for different calf circumference values and their specificity and the accuracy. The cutoff points for calf circumference were identified with respective values, and the confidence intervals of sensitivity, specificity, and accuracy were calculated. Next slide. For analysis, Pearson correlation was used to substantiate that CC CC is more important, or it is as important as DEXA scans, because we know the DEXA scans, they provide definitive value. We have to show that the calf circumference can be used. So they used Pearson correlation. 0.7 was the result, so it showed a positive correlation. T-test was used to confirm the mean of two variables. It was 5%, so the findings were significant. And the receiver operating curve was also used to compare the different calf circumference values and to find which calf circumference value can be taken to identify sarcopenia in older women. So ROC was used to select the cutoff value and to assess the performance. More than 0.8. So the more than 0.8, it showed a good value actually. Next slide, please. From this table, we find the three cutoff points were used: 30 centimeters, 32 centimeters, and 33 centimeters. And the study found that if the cutoff point is 32 centimeters, there was a good accuracy of around 80%. Of the 30 women, 15 women had sarcopenia with the DEXA scan. Here, 21 women showed sarcopenia if the cutoff of 32 centimeters was used. So the sensitivity was 100%, the specificity was 60%, and the accuracy was around 88%. If 33 centimeters was used as a cutoff, the sensitivity was still the same, 100%, whereas the specificity decreased. If the cutoff was reduced to 30 centimeters, we find that only 11 women were found of the 15 who had real sarcopenia. So the sensitivity decreased, whereas the specificity increased. So the ideal cutoff point can be 32 centimeters. Next slide, please. This is with the DEXA scans. This table is of the DEXA scans. They found that of the 15 women, if the age increased, the ASMI decreased. It was a significant variable. So more than 70 women, of the 3 women had a low ASMI. 80% of the women that was a significant variable. 80% of the women had a BMI of 23 to 25. They had low ASMI. That is not significant. Whereas 86% of the women with more than 10 years of menopause had low ASMI. So as the menopausal age increased, the muscle mass decreased. That was a quite significant finding. Next slide, please. This has already discussed actually. If 30 centimeter is used as the cutoff, of the 15, they found that 11 women had sarcopenia. So the sensitivity was quite low, whereas the specificity was high. Next slide, please. If 32, two have been compared actually. The first is for 32 centimeters and the next is for 33 centimeters. If 32 centimeters was used as the cutoff, 21 women had sarcopenia out of 30 women. Whereas if 33 centimeters is used as a cutoff, 22, that is just one person had an extra sarcopenia, but the specificity was so low. Next slide, please. So the result and the conclusion, 21 out of 30 women were found to have sarcopenia if 32 centimeters was used as a cutoff. The sensitivity was 100% and the accuracy was 80%. The conclusion, calf circumference can be taken as a reliable tool for measuring sarcopenia in Indian postmenopausal women. Next slide, please. Discussion, as the human ages, there is a decrease in the muscle mass. DEXA scans are accurate, but they are very expensive. If we take the cutoff from 31 to 35, it hinders our clinical judgment and we can't plan a therapeutic management properly. Calf circumference is a low-cost, affordable one. Regarding the sarcopenia, Japan, it has published clinical guidelines in 2018, and the European Working Group on Sarcopenia in older person issued a consensus in 2018 that muscle strength can be used to assess sarcopenia. To assess the muscle strength, they used few tests like the chest stand test and hand grip test and all. Next slide, please. Using Western criteria, Asian people diagnosis might not be appropriate because we Asians, we are small, more active, and we have more fat. So CC is a good predictor for the muscle mass index. Mexican study, French study, they use 31 centimeters as the cutoff, whereas the Indian women 32 or 33 centimeter might be a better predictor for low muscle mass. Thank you, ma'am. The other slide is just citing the reference articles.
Thank you, Dr. Ranju. It was a very, very nice presentation, very clear cut. You have made wonderful slides and you have explained it, very nicely. First, I want to have, inputs from Dr. Sheila Mane, Dr. Hepzibah.
Yeah, as Dr. Sudha rightly said, I think it's really a nice.
Dr. Sheila, can you please put off your video?
Yeah. Is it now? Can you hear me?
Yes,
Yeah, now it's
we
better.
can hear you very clearly.
Yeah. Yeah. As you said that I mean, she said that the sample size was small, but it is such an important study that it tells you about sarcopenia and all these things. And I think the viewers today, am I audible?
Yes,
Yeah.
yes, very much.
Am I audible?
Yes,
Yeah,
we
we
can
can
hear
hear
you.
And I think definitely the viewers, the viewers today will definitely, I think, benefited because, we have to really look into all these things, I mean, overall, we just try to treat them, but, this study on sarcopenia, muscle mass and looking at the bone density and all that, I think it really throws light on the women's health because it is so important as they are aging. So I think it's nice that this study was chosen to be presented. Yeah.
Thank you, Dr. Hepzibah.
Yeah, that is a good study and a useful study and a simple tool to assess sarcopenia. And the way she was selecting the cutoff, when the specificity is increases, that part is very, very important. We have to be, that specificity and sensitivity calculation is very important for any tool to fix it. And since it can be done in any OPD, this study can be very much useful in all the study can be. This methodology thing, you could have combined it with other SCARF score also. The next time somebody is doing that, they can compare it with that also. So it's a wonderful presentation. It's congratulations.
So thank you, Dr. Hepzibah, for that input, wonderful input, and Dr. Sheila also. I think Dr. Renja, this is Renuja, Dr. Renuja.
Renju, ma'am.
Ranju, okay.
Dr.
Sorry,
Sudha?
I'm pronouncing it
Dr.
wrong.
Sudha?
Yes.
So because I think
Yes, Dr. Radhika.
Yeah, I just wanted to also discuss this out because I can't see Dr. Anju, but I think Dr. Ragini has just joined, but she may not have heard the presentation. So I was just curious to know, Renju. Hi, Dr. Ragini, welcome.
Hello,
Yeah,
Namaste,
yeah.
Dr.
So
Radhika.
Dr. Radhika, I just needed to tell that why I chose this topic for discussion because sarcopenia.
Acha, okay, the topics were selected by you, was it?
Yes. The first one. The second one was by Dr. Hepzibah. Because this is the least discussed, most neglected, and the least interested topic. But the impact it has, but it impact it has on the aging population is huge.
Certainly,
and number two, and number two was there is a paucity of literature, Indian postmenopausal females. So, and since, the evaluation of muscle mass that requires, cost investigation, including MRI and CT, this anthropometric measurement, they have been recommended as an alternative. And calf muscle is, a good alternative. The primary aim was to see whether it is a good alternative. And the secondary aim, I think Dr. Ranju has told us that it has given us additional cutoff points. So both the aims, they have been fulfilled. The only thing is the study is of, the short duration, small number of cases have been taken. And what I am finding in the, if you look at the study, it has been done in Delhi hospital, but there is another name, which is from the, Vajpayee Institute of Medical Sciences and
It is the
PGMI.
same one. It is the same one.
It
Atal
is the
Bihari Vajpayee, RML Hospital.
Okay, all right.
So I just wanted to add a comment. So I congratulate you, Dr. Sudha, for choosing this, and Renju, amazing work done. But since we are discussing a journal club, I think we need to also understand a few other aspects to the study. So, Dr. Renju, are you there?
Yes, ma'am.
Yeah. So we couldn't see your video, so that's why. So very obviously, Dr. Sudha, and you have highlighted the importance of this topic, that the muscle mass, and we understand, because we have been emphasizing on the physical activity, because it is only the strengthening of the muscle which helps to provide support to the bones. So the muscle mass is extremely important, especially in the menopausal age group, because they are the ones who have, there is, deficiency of hormones, calcium, broken bones, so many things are happening. But, it is not the topic that we are discussing. It is about the methodology, because we as people here are also important for us to understand the strengths and limitation of anything that we are discussing here, right? So the strength is that it is an important clinical topic and it is of relevance to us. But what do you think are, the limitations if you were to undertake such a study? So what are the things that you would actually consider in filling the plugs that you found in this study? Because having sensitivity, specificity from a handful of number, with so many limitations and confounders there, how much, what could be the, what is your thought on the matter? Because I'm sure you must have gone through this study n number of times.
Yes, ma'am. What I did was, because
Yeah.
the study was very, very small, ma'am. Only 30 women were included. This is not correct for a to arrive at a proper conclusion, ma'am. The other studies like Mexican, French, and all, they showed a specificity of only 40, sensitivity of 41% and 31%. I was like perplexed, like how can our study be so sensitive around 100%?
Exactly.
And I
Absolutely.
thought women are all they have low muscle mass. That was
Yeah,
how.
so it adds to a lot of, this is, so when the point I wish to make here is that whatever we read, it is important to critically appraise the literature. It might appear very attractive in terms of the title, and we as clinicians, because we are sitting day in and day out in the clinics, and the mind is full of questions. So we suddenly come across a study which appears to be answering our question, but we need to also critically appraise that literature in terms of its methodological aspects, in terms of validation. If the same study were to be repeated elsewhere, the studies have to be similar, if not the same, right? So, and then there are innumerable number of confounding variables. Here you said the exclusion was obesity, but then I can also see, and then there was a line that you said that Indian women had more fat on their bodies. Is it really the case? Asians?
Yes.
You said they are more
That's
active,
right.
but they have more fat.
More fat. Adipose tissue is more.
They are both of them are counterintuitive. So there is, maybe the distribution of fat is different, but is the total content of fat in the body different? So the idea was to basically draw your attention to the critical aspects of this study. It's a well presented, good topic, but we as researchers and clinicians, we need to be carefully assessing the study, right? The good part was it's done by the Indian scientists, the researchers, and all that. Great. So we are very happy to have Dr. Ragini and Dr. Anju. And Dr. Sudha, we just missed introducing all of you. So because others had
That's
not joined,
okay.
I just, no, I'll just do that quickly. I just interrupted for that reason because I wanted to introduce all of you. So I hope my screen is visible. So
Yes.
we are, okay, great. So we are very happy to have with us Dr. Sudha. She is the former professor in the Department of Obs and Gynae at GMC Jammu, J&K. And she's the Vice President of IMS 2024-25, Secretary General IMS 21-22. And the entire screen is filled with her positions and awards. So warm welcome to you, Dr. Sudha. She is, other than the expert, also coordinating the session today. We are happy to also have with us Professor N. Hepzibah. She's a former superintendent of government RSRM Hospital and Professor Stanley Medical College at Chennai. And she's currently at Savita Medical College at Chennai, and she's the past president of Obs and Gynae Society of South India, vice president of Chennai Menopause Society, and there is a lot of activity on the radio awareness programs and TV programs. Welcome to you, ma'am. A lot of accolades and so many chapters that she's contributed for the books. Dr. Sheila Mane, we all of us are, because she joins us in all the programs, we are very familiar with her. She is the ICOG Vice Chairperson currently and DNB faculty for KC General Hospital, member of IMS Bangalore Society of Obs and Gynae, FOGSI Isopark, past president of ICOG, and so many accolades and publications. Welcome to you, ma'am. Dr. Ragini, she is the founder and president of the Indian Society for Aesthetic and Regenerative Gynecology, founder and president of Indian Academy of Cosmetic Dermatology and Gynecology, founder president of Elect North India Gynae Forum. Dr. Ragini, you are the founder of many things. So we are extremely happy to have you here. We are honored to have you. Warm welcome to you. And Dr. Anju Soni, very warm welcome to you, Dr. Anju. She is the president of IMS, current president, secretary general of IMS, elected governing member of the governing council of ICOG, member of India CCM, chairperson HIV/AIDS committee FOGSI in 22-23, and there are innumerable major achievements and honors and awards. Welcome to you, a warm welcome to you, Dr. Anju. So as you can see, now we have finished with the first session, and now we are going on to the second session of presentations. So over to you, Dr. Sudha again. So I just presented the slide of. So Dr. Vidya, I think you need to introduce yourself because I think you forgot to send your slides, introduction slide.
Ma'am, I sent it yesterday, but
Okay.
yes, good evening, ma'am. Very happy to be part of this journal club today. Thank you for having me. I am Dr. Vidya Lakshmi from Coimbatore. I'm a consultant gynecologist and fertility specialist at Excella Women's Specialty Center. I'm also a visiting consultant at PSG Hospitals in the department of ART.
Welcome. Over to you, Dr.
Thank you,
Sudha.
ma'am.
Welcome, Dr. Vidya Lakshmi, and the second topic is displayed on the screen, and we invite you for your presentation, please.
Thank you, ma'am. Today I'm going to be presenting this article, one of the very rarely addressed topic when it comes to menopause or any other condition in women's health. This article is titled as Role of Social Support in Reducing the Severity of Menopausal Symptoms Among Women Living in Rural Mysuru, Karnataka. This is an analytical cross-sectional study. Next slide, please. So this is an original article published in April 2024 from the same journal as from which the article was presented before, the Journal of Midlife Health. This is an open access journal published by Wolters Kluwer. And the study itself comes from the School of Public Health, JSS Medical College, Mysuru. Next slide. So, talking about the background of the condition, although a woman spends almost 1/3 of her lifetime in this particular phase of menopause, it is one of the most unspoken aspects when it comes to women's life. And the postmenopausal syndrome includes a various spectrum of symptoms like hot flushes, night sweats, which constitute the vasomotor symptoms, irritability, mood swings, insomnia, concentration issues, mental confusion, genitourinary complaints like stress incontinence, OAB, vaginal dryness, osteoporosis, all of which could cause significant anxiety and also depression. And these symptoms and their severity vary significantly with respect to the age, race, as well as ethnicity. Next slide, please. And women, when it comes to the Indian scenario, are largely unaware of the symptoms of reproductive senescence. Many of them consider it to be a natural transition from the reproductive age into old age. And there are a whole lot of taboos as well as myths surrounding menstruation and the stop of menstruation among Indian families that they hesitate to come out in the open with their complaints. And also fewer sources of health information and poor access to healthcare in the rural scenario adds to the suffering. And there are evidences to show that social support from close ones can reduce the anxiety, improve the self-esteem, and help them cope up better with the symptoms of menopause happening during the transition, and thereby improving their quality of life. However, when it comes to South India, there are not any studies to measure the impact of social support on the menopausal symptoms. Next slide, please. So, aims and objectives of the study. This study aims to investigate the severity of the menopausal symptoms among rural women, to investigate the relationship of perceived social support throughout the menopausal transition in rural areas of Mysuru. Can you change the slide? So, materials and methods. This is a community-based cross-sectional study conducted in around 26 rural villages of Mysuru district, Karnataka. The study duration was about 8 months between May and December of the year 2022. Inclusion criteria. Next slide. So, postmenopausal women who experience natural menopause and women in the postmenopausal period between 1 to 5 years of obtaining menopause who had the ability to provide an informed consent for their participation in the study were included. And exclusion criteria. Next slide. Women who had an unnatural menopause, that is surgical or by chemotherapy, hormone replacement therapy, women who are on medications like psychiatric medications, menopause happening because of certain autoimmune conditions and certain genital pathologies, and because of certain other physiological and pathological conditions were excluded from the study. Next slide. An institutional ethical committee approval was obtained before undertaking the study. And the data was collected using an interviewer-administered survey in the local language from 250 participants in the selected villages from Mysore district. The data collection was done over 3 months between June and August of 2022. The details collected were the socio-demographic details of the woman, including the current age of menopause, religion, type of family, whether it was a nuclear family or a joint family, the educational status, occupational status, marital status, and the socioeconomic status assessed using modified Kuppuswamy scale, were all the demographic details that were collected. The menopausal symptoms and their severity was assessed using a scale called as menopausal rating scale, and their perceived social support, what they obtained from friends and family and other close ones, was assessed using MSPSS scale, multidimensional scale of perceived social support, which I am going to be displaying in the subsequent slides. Next slide, please. Can you change the slide? Yeah. So this table shows us the menopausal rating scale. So the menopausal rating scale basically contains 11 questions grouped under 3 domains. These are basically symptoms of menopause, which include somatovegetative, psychological, and urogenital symptoms. And the person answering this questionnaire could grade the symptom as anywhere between 0 to 4, 0 being none when they are not experiencing the symptom, and 1 to 4 being mild, moderate, severe, and very severe. So a total score of 0 to 44 was assessed from each person. So thereby rating the scale. The questions include hot flushes, sweating, heart discomfort, sleeping problems, depressive mood, anxiety, physical and mental exhaustion, sexual problems, bladder problems, dryness of the vagina, joint and muscular discomfort. Next slide. And they assess the perceived social support based on this MSPSS scale. So wherein there were 12 questions, and The social support obtained was graded between 1 to 7 based on these questions, and their support and help that they could obtain was assessed based on 3 domains: support from friends, family, spouse, or special someone. So whether they had a special someone when they were in need to share their joys and sorrows, when they whether they had a family to help them in times of need, whether they had a person to real source of comfort for them, and friends, whether they would really try to help them, whether they can count on people when things go wrong, these kind of questions. And they could give the answers between 0 to 7, whether they very strongly disagree, mildly disagree, neutral, mildly agree, strongly agree, and very strongly agree. So the grading for each of the question could be given anywhere between 1 to 7. So the total score would be anywhere between 12 to 84. Next slide, please. So the sample size was 250. This was calculated from a previous study, which had a mean score of 20.6 for menopausal symptoms with a precision of 5% and 95% confidence interval to yield a sample size of 240. And this was rounded off to 250 and used in the study. Data analysis was done using SPSS software version 25. And descriptive statistics were described in terms of percentages and frequency, and degree of association between the socio-demographic variables and severity of menopausal symptoms. Association between demographic variables and social support was expressed in terms of chi-square test. And the association between menopausal symptoms and perceived social support was quantified using odds ratio. Next slide. So the data collected in the study has been tabulated into 3 main tables. This is table number 1, which is the comparison of socio-demographic characteristics of the study participants with the menopausal rating scale. That is the severity of menopausal symptoms. So a total of 250 women from 26 rural villages were collected, and the demographic characteristics collected, as I had already mentioned, were age, education, occupation, family type, marital status, etc. And it was tabulated in this manner. The age of the women were ranging between 40 to 60, with the mean age of them being 50.9, and the mean age of menopause was around 47.6. Next slide. So we can see that the predominant numbers were belonging to more than 51 years of age, and almost 70.4% of the women included in the study were not educated, come under illiterate category when it comes to the assessment of education. Next slide. .8% of the women included were homemakers, and a small percentage were unskilled and semi-skilled workers. And more than 50% also lived in nuclear families. Next slide. When it comes to the marital status, nearly 77% of the women included in the study were married, and most of them belong to lower socioeconomic strata. Next slide, please. And as a split up of the symptoms experienced by them, nearly 71% of the women had symptoms confined to the psychological domain. 80% of them had joint and muscular discomfort. 68.8% had irritability. 69% mood. 66% had mental exhaustion and genital domain, which only 16.4% of them complained of. And what we can see from the table is that nearly 56.8% of the women suffered from moderate to severe symptoms. And one more important thing to note here is the p-value based on the first table. None of the socio-demographic variables like the age, educational status, or occupation, or the family status, marital status had any significant relationship with respect to the severity of the menopausal symptom. The p-value in all of the variables was more than 0.05, did not show any significance. Next slide, please. So this is the second table, which compares the socio-demographic characteristics of the study participants with the perceived social support. So what we can see here is that the marital status of the person when it was married, it does seem to have a significant difference when it comes to social support. So only the marital status as well as the socio-economic status, the p-value is less than 0.05. So the marital status and socio-economic status that has a significant relationship when it comes to social support. Next slide. So this is table 3, which assesses the association of socio-demographic variables and the social support with severity of menopausal symptoms. So what we can see here is that women who are never married, separated, or divorced seem to have an odds ratio of 1.5 when it comes to the severity of the menopausal symptoms. So this shows a positive association. This is almost, that means women who are unmarried or single are 1.5 times more likely to experience severe symptoms of menopause. And when it comes to social support, we can see the odds are more significant. Women with low to medium social support have are showing almost an odds ratio of 4.5 times more likelihood of experiencing severe symptoms. Next slide. So an unadjusted odds ratio was computed between the severity of menopausal symptoms and social support. An association between menopausal rating scale and MSPSS social support scale seemed to be significant with a p-value of less than 0.05, and the odds of experiencing moderate to severe menopausal symptoms were almost 4 times higher among women who perceived low to medium social support when compared to those who had a high social support. Next slide. So discussion. Perceived low levels of social support. Women who perceived low levels of social support were more likely to experience severe menopausal symptoms. There were no significant difference between the severity of menopausal symptoms in terms of socio-demographic graphic characteristics, as we already saw in that table. And women who had little or no menopausal symptoms belonged to the age of obtaining menopause at 45 years or younger. And most of the women who obtained menopause after 45 years seem to have moderate to severe symptoms, which constituted almost 59.6% of them. And there is a statistically significant association between perceived social support among women and marital status and socioeconomic class. Next slide. So studies which talk in favor of the finding. There is a study, Turkish study done by Erbil et al. Found that the social support was higher among women with higher socioeconomic status and women who were single, which is definitely contradicting what is given in this study. Social support was found to be a significant predictor among menopausal symptoms by a study done by Alufi et al. And there was a study done in the US which was contradicting this finding by Arnott et al., which showed that increased social support is not associated with decreased menopausal symptoms. Next slide, please. Every study has its strengths and weaknesses. When it comes to this study, the main strength being it is addressing something that has not been studied in large. This is the first study from India to examine the relationship of menopausal symptoms and perceived social support among postmenopausal women. And the study contributes to novel findings on perceived social support of postmenopausal women in rural Mysuru. Limitations of the study. Next slide, please. The study used interviewer-based survey, which is prone to recall bias because of self-reporting of symptoms. And the stratification of relationship of the individual who provided the social support was not discussed. Although the scale which assesses the social support does have questions separately for the support obtained from spouse, friends, and special someone. So the stratification could have been done. The health literacy was not assessed, which could have played a major role in expressing the experience related to menopausal symptoms. However, we can say that almost 70% of the women included in the study were illiterate. So it is very unlikely to assess health literacy in this kind of a population. The study tool was translated to local language Kannada, but it was not translated back in English, so which might have affected the accuracy. The data collection was done in the community at the residence. So hence, they could have excluded a few working women as it was done at the residence during working hours. Any other health-related ailments and past medical surgical history, the data pertaining to this was not collected. And this could have also attributed to the severity of menopausal symptoms. So this was one thing that was not assessed in the data. And other possible confounding variables that could have influenced the outcome have not been accounted for. Next slide, please. So to conclude, the study suggests that there is a need for active involvement of family, friends, as well as community in order to provide the required support during the transition to menopause, which is definitely a tough phase. Seeking social support by menopausal women can be enhanced by their level of awareness of the symptoms per se. Hence, menopause health-related education and community-level health programs have to be implemented, especially among rural women. A social solid network and receiving more social support might lessen the frequency as well as severity of menopausal symptoms. And health centers also can concentrate on offering regular health education programs in order for the families to understand the value of providing support for women who are going through this transition. Thank you. That concludes the study. Thank you very much for giving me the opportunity to present. And I request the experts to give your valuable opinion and comments.
So thank you, Dr. Vidya Lakshmi. That was a great presentation and very beautifully you have, highlighted the strength and the limitations of the study. That part I have really liked. That means you have thoroughly, understood it and you've taken out the limitations of the study. And now we have, Dr. Ragini.
Thank you, ma'am.
Thank you, Sudhaji. Namaskar, Radhika ji. Namaskar, Anju ji. Vidya, very nice presentation.
Thank you, ma'am.
Only thing, no doubt, the study was very good, as Dr. Sudha has said. Everything has come out. But surprisingly, one factor which has come out that in this population which we have studied is very different from the other problems which is being projected, basically the genitourinary syndrome of menopause. Because in this study, only 16% people are come with this complaint, which is considered one of the major complaint among the menopausal women, at least in the educated women in the urban areas. So this is a very contrast. Maybe one factor is because these women are not ready to talk about the sex. That might be a major reason, not ready to talk about the vaginal problem. So I don't know, because in our OPD also the people are coming with the GSM a lot. This the only thing is surprised me a lot.
Dr. Radhika, but the only thing what I am finding in this, Radhika, if you look at the paper, it is from School of Public Health, JSS Medical College, Mysore, Karnataka. And the second one is, the contributor is from USA.
Yes.
So did you notice that, Vijay Lakshmi?
Yes, ma'am. Yes. I think there's two of the authors are affiliated to both JSS Public Health School as well as USA. So the affiliation is to both the places. That's what's mentioned.
Dr. Radhika, what is your take on this? Is it a gift authorship?
That might be, but then
That
I'm
the
sure
study has
at the end of this publication, I'm sure the contribution of each author is already stated, because that is the mandate by the ICJME, the international collaboration of the Journal of Medical Editors. So the publication will only happen once you are clear about the contribution of each of the authors. So nowadays, with the world shrinking with the digitalization and easy communication, collaborations are very frequently happening. So
but
it
I
could
think
be,
that should be, yeah, that should be mentioned and that should be highlighted and that should be presented.
the other possibility is that this could be a part of a major another project that they were working on, which would also be mentioned in that publication. If it was a part of, there are various ways of publishing. So it could be salami slicing. You have a
Yes.
large data and you present small data here and there. That is one thing. Or the aim was something else. The objective of the main study was something else, and they have something as a secondary outcome, and they have decided to publish that. So there are
So
various
that's,
reasons why this could have taken place. So I'm sure between the lines, Vidya would have seen it. And
yeah, but
yes, but we need to
reasons,
also
yeah,
Yes,
many, but it should have been, clarified
I should
and
have
it should have been
presented
mentioned.
it. Yes,
no,
yes.
that's okay. That's
That's
okay,
okay.
Vidya.
It's not your this thing. It should have been mentioned in the paper itself.
Normally, people may not even, it's not a part of your journal club presentation
Yes.
why authors of different continents collaborated. You may
But
not do
once
that.
you are, but once you are, looking at the paper, what I feel is the presenter should look at these points as well.
Yeah, correct.
Yes.
Dr. Radhika, you want to add on something?
Dr. Ragini, you mean? I think.
Ragini,
Yeah.
Dr. Okay, Dr.
From my
Radhika.
side, everything is very fine. The only point which is really clicked me is this, because we have to see in it. We are talking in the Menopause Society all the time about the GSM, and here only few women are coming with this problem. So we have to look in it whether it is really bothering them or they are shying away with this.
Yeah, very right, Dr. Ragini. If you look at the incidence and the prevalence of GSM in Indian females, it is quite high as contrast to this study.
It needs awareness, a lot awareness.
Okay.
Yeah.
So I think, Dr. Radhika, we can conclude with this.
I think one of the reasons, Dr. Ragini, why people don't actually come to the gynecologist, हमारे में ना acceptance बहुत है. People feel कि अब तो इस उम्र में तो होता ही है.
हाँ, यही अवेयरनेस चाहिए कि इसका इलाज है, why suffer.
So our women have a great tolerance in terms of quality of life. And number two, of course, the societal norms. People hesitate to come for these kind of problems. So as Vidya had very nicely highlighted, social support, not only by way of accepting the changes, but also bringing the woman to the doctor, helping and supporting her to get to the medical personnel, I think is also an important aspect of the support that we talk about.
Oh,
so is Dr. Sheila there? Dr. Sheila Mane and Dr. Hepsiba?
Patient yet to come.
Yeah. Dr. Sheila is there. Please, madam.
Yeah, I'm there. I think the host is not allowing me to open my video. That is okay.
Okay.
As I think all of you have assessed and told about this study, it was good. It was done in a rural area. And I think most of the women in rural area, they do feel that social background, I think they are socially supported. So actually, I think in rural areas where there may not be that much a problem, but in urban area, I feel that the problem is more because most of them are nuclear families, or sometimes they are staying alone because the children are not here. So that empty nest syndrome is also there. And if the husband is sick, definitely the social support is not there. The urban woman definitely faces a more problem, I think, they have more difficulties. Rural people, somehow there will be people to support them. So, and as this study was done in a rural area, or also,
me?
you know, the scores will not be that high.
Dr. Anju is trying hard to, you know, unmute herself. Please, technical system, unmute Dr. Anju.
Ma'am, we are sharing
हमारी
here.
आवाज भी आ रही है और शक्ल भी दिख रही है.
But Anju is not able to unmute.
Ma'am, from
Sheila
here
is
we
not
are
able to
sending
show her.
a request to unmute, but ma'am couldn't click on the unmute.
खुशी, who is खुशी? I think सुधा जी ये एक बहुत अच्छा टॉपिक लगा है मुझे. इसको एक स्टडी की तरह हमें IMS में मल्टी सेंट्रिक लेना चाहिए. बहुत बढ़िया टॉपिक है.
Yes.
बहुत सिंपल, कोई इसमें ज्यादा पैसा नहीं लगना, कोई स्पेशल इंस्ट्रूमेंट्स नहीं लगने,
कुछ नहीं, क्वेश्चनर है, सिंपल ऑब्जर्वेशनल स्टडी है.
इसको अगर हर मतलब हमारे 1000 मेंबर भी अपने पेशेंट्स के बीच में इवेल्युएट कर लें एज अ डिफरेंट प्लेस. आई थिंक यू आर कमिंग आफ्टर अंजू and Anita, maybe in Anita ji's year or your year, we can take it.
Sure. That's great idea. But again, Dr. Anju, please, she is, you know, not able to unmute. Dr. Radhika?
Yeah, ma'am, also, we are also from here sending a request to unmute the mic.
So now we will move to the second then. There's another one, huh?
No. The first one is done. I think,
क्या
sorry,
आप जब
Dr.
बोल रही
Anju.
थी, आप जब बोल रही थी, ओके, मैंने सुना था वो वाला हिस्सा जब आप बता रही थी.
That's done.
Yes.
Okay. So, Dr. Radhika, can we conclude? Dr. Anju,
yes.
unfortunately has not been able to unmute. Sorry, Dr. Anju, they are trying hard to unmute you. I don't know where is the problem.
Even they have problem with my video. They can't switch on my video. Sudha.
Oh, okay. Yeah, I can't see you, Dr. Sheila.
ये strength है.
Now they did it. Now
yes. No, we can see.
एक का strength तो आ गया. डॉक्टर अंजू की कमियां रह गई, हाँ, स्टडी की तरह, एक स्ट्रेंथ और एक कमियां.
चलो. So I think what Dr.
No.
Good idea. As
Dr.
it is a
Anju,
study.
Dr. Anju.
Ma'am, do you mean me?
Dr. Anju, you can speak on this.
Ma'am, do you want me to speak about sarcopenia, ma'am? Did you mean me? I thought it was Dr. Anju Soni, ma'am.
Okay.
Yeah, it is to Dr. Anju Soni only. Because she's not able to unmute.
Were really good.
I have.
Both the sets were really good. And I'm sure we need to, because sarcopenia is a new term, just few years back we have started knowing about sarcopenia, which is a very neglected section of us. And we need to really concentrate on that. And the measures used were very, very simple. I can't unmute myself as well. And we must, Dr. Sudha is well said, we must look into that, and this social support study is also very important. And Dr. Rajni has very well pointed that people don't come forward until we ourselves ask the leading question about DSM. They are shy about it because of the culture, and they do not have any expectation from the part of people that they be cured. DSM also is a very, very important aspect which we need to go deeper to understand. Yeah.
Okay.
So I'm going to log out now. Thank you so much for all the work. So I don't think I'll be able to be there.
Okay, so
Thank you so much.
Dr. Anju, we have got your message. This way or that way.
Nice. Thank you so much. Thank you so much.
Bye. So it was through the phone. She has given us the message, and I think, Dr. Radhika, we can now conclude the session.
Certainly we can. I think it's been a very interactive, informative session.
Interactive.
So
Yes.
thank you
And
very much. Thank you,
you know,
Dr. Sudha.
every time we do such kind of activity, we learn from you, these juniors also, the way they are presenting, and your slides are also very good, Dr. Radhika. We have also learned a lot from this.
Thank you. Thank you so very much. So thank you, experts, and thank you, presenters. It was indeed a very informative session. Thank you all. Have a good day.
Thank you.
Namaskar.
Thank you.
Thank
Bye.
you.
Thank you.
Namaskar. Bye.
So thank you so much, everyone. Now, so from here, I'm ending this meeting. Thank you.